Good afternoon and welcome to United TV. My name is Kemal Erkan. This is our Bariatric Friday and I'm here with Dr. Isaias Irgau. Today we are going to talk about risk and complications of bariatric surgery. As we have discussed in the past, bariatric surgery is the most powerful tool for weight loss. This is with the significant weight loss, effectiveness in treatment, for long-term results. So bariatric surgery is way to go. That's why we discuss this every week. And of course, understanding risk and complications is important. Understanding why certain things could happen and what we can do, how we are prepping our patients. So when it comes to risk and complications, we are going to actually look at it from the short-term and long-term standpoint. So our expert is with us, Dr. Irgau. How are you doing?
I'm doing great, Kemal. It's glad to be back on yet another wonderful session of Bariatric Friday. This is a critically important topic that we have covered in the past, but obviously we have to keep on covering because it's part really of the educational process for our patients. Clearly, as you mentioned in your introduction, we're offering the most effective treatment currently available for severe obesity, bariatric surgery. And as part of the process of understanding the indications of the surgery, obviously we have to be getting our patients well informed about the potential complications of the surgery. The big picture first, Kemal, and that is bariatric surgery has become an extremely safe procedure, right? In a way, the fact that it has been treating morbid obesity, which is a condition that has been so highly stigmatized in our society, has made bariatric surgeons the target also not only of the society in general, but also of the medical establishment for many years as doctors who were really treating something that was not needed, right? As you recall, it's only been less than 10, 15 years since even the American Medical Association actually classified obesity as a disease. So we've gone for many years without really recognizing obesity as a disease. Therefore, bariatric surgery was seen in a fairly bad light for many years, and it had to really legitimize itself. Because of that, bariatric surgery has been under enormous scrutiny, right? And we had to really show that not only we had a great effective treatment at hand, but we had to make sure that it was safe as well. And because of that, bariatric surgery has undergone tremendous study, probably one of the best studied surgical procedures currently, right? And as a result, we have made huge improvements in safety to the extent that complex procedures like gastric bypass or sleeve gastrectomy now, Kemal, have the same safety profile as gallbladder surgery, hysterectomy. In fact, there are some papers that show even greater complication rate for gallbladder surgery compared to bariatric surgery. So that's where we are. Bariatric surgery has indeed become an extremely safe procedure. Having said that, it is still surgery. And like any surgery, there is potential for complications. And as you said, it is useful to look at the short-term complications and long-term complications, right? So short-term complications of the different types of surgeries, and we obviously have the gastric bypass, the gastric sleeve, the most commonly done procedure, which are procedures that are intended to somehow modify the digestive tract. Infection can occur. Infection can occur in the short term because the stomach has not healed well, the intestine has not healed well, a leakage can happen, right? This can lead to a very serious infection. The good news, as I said, is again, this is an extremely rare event in programs like ours, where we've achieved such great levels of safety. But even if it occurs, obviously, we can take care of it, right? When does this type of infection tend to occur? Well, it tends to occur in the first 30 days, perhaps in the first 6 weeks after the surgery, right? And when we tell our patients about this complication, we also instruct them about calling us if they have certain symptoms, right? Whether it's abdominal pain, fever, vomiting. All these could be signs of a potential complication, and they need to alert us so we can take care of it in a timely fashion. Other things that can happen early after surgery include things like blood clots, right? Blood clots that can happen in the legs, that can travel into the lungs. This could be serious complications, Kamal. But again, we've made big strides in minimizing this complication. In fact, one of the increased risks for blood clots, Kamal, in any type of surgery are patients with a high weight. So our patients, by definition, have an increased risk for blood clots when they undergo surgery, because we've recognized that we've gone out of our way really to place prevention measures that have helped us greatly. In fact, as you know, all our patients just before surgery get a blood thinning medication, right? And
Dr. Irgau,
yeah,
blood clot. So because again, we go through our case conferences when the patient is signed up. We review those patients after their surgical appointment. So in many cases, patients don't know that they have potentially they may have blood clots. They may have other risk factors. So these are risk factors for the surgery. But the point I'm trying to make is, in many cases, patients don't know that they have these conditions because they are never being tested or no one has asked them before. So my point is, when they may have some other emergencies, they may be actually dealing with those emergencies without knowing that they have these risk factors. So, for example, the patient with blood clot problem may have an emergency gallbladder surgery, right? So when these are of course risk factors, and we are looking at how we actually preparing our patients. But one of the big benefit of it is for patients, even if they don't go through the procedure, they need to understand that they have these conditions.
absolutely, absolutely. So from the get-go, when we evaluate our patients to see whether they are candidates for bariatric surgery, and then if we come to a common understanding between us and the patient that bariatric surgery is needed, necessary, appropriate in their situation, and we start the process, at that very moment, we also start the process of looking for potential risk factors for complications so that we can address them in a timely fashion. And as you correctly said, we look for clues as to whether that patient is at greater risk for blood clots, for instance, right? By just being heavy, for instance, the patient is already at higher risk for blood clots. Well, what if they've had a history of a blood clot in the past? What if they've had a history of blood clot in their family? Right? What if they've had a history of cancer in the past? What if their age is above 40? All those are risk factors that they are incrementally going to increase their risk for blood clots. Well, that puts us on alert that we have to put more measures in place to protect that patient from blood clot, right? As you know, for instance, there are patients that we send home on blood thinning medications after surgery, right? Now, this may sound counterintuitive because you're doing surgery on somebody who is at risk for bleeding, and then you're giving them medications to thin their blood, which decrease their ability to clot, which means that they are even at greater risk for bleeding. But then we are in that special situation where we have to look at the risks and benefits of each potential risk of bleeding versus risk of blood clots.
Like
Clearly,
risk so that
yes.
we pick the less risky one.
Absolutely, absolutely, absolutely. Well, and also, as you know, because we do our surgeries laparoscopically right now, the risk of bleeding has decreased greatly compared to the past when we used to do open surgery and we had the surgeon's big hands inside the abdomen manipulating structures, which had a high rate for bleeding, for instance, right? We don't do that. We use laparoscopy, which is very tiny instruments that manipulate the tissues very delicately. So the risks of major bleeding is very low. In fact, after laparoscopic surgery, one of the questions the anesthesiologist will ask the surgeon is, hey, what was the blood loss with this surgery? And normally it's 2 cc, 2 mLs for such a big procedure, right? So bleeding is minimal. And because we're so comfortable with our ability to control bleeding, then we can give blood thinning medication to protect against blood clots, right? So, and then we can talk about bleeding. Bleeding is by itself a risk as well. Like this could be external bleeding, it could be internal bleeding. And obviously, we take measures to minimize this. For instance, when we are doing the sleeve gastrectomy, Kamal, as you know, because you have all the expenses from the surgery center and you see, the expenditure that the surgery center has to do, for instance, with gore, right? Because you get us a material from gore that helps us really to buttress the wound on the stomach that really decreases the bleeding considerably, right? And we are able to sleep better because we are controlling a risk of bleeding in that way. So big potential complications could be life-threatening, like infection, like blood clots, like bleeding. We're addressing them proactively. That's why the rate of this complication is very low. Obviously, other complications that can occur are anesthesia-related complications. Again, we are very proactive, right? In our case conference today, you were talking about a patient that the anesthesiologist wanted to assess before surgery to look at their airway, right? To see whether the airway was going to be an issue for them to be prepared. So it's all about being proactive and having systems in place to protect the patient against complications. Now, when you do all this, Kamal, what you do is reduce the risk of complications. You can never bring the risk of complications to zero. There is no such thing, right? But you're reducing it to levels that are really acceptable, low levels, so that when we are evaluated by the accreditation bodies that come and give us the Center of Excellence status, they look at our complication rate. They're very comfortable with the fact that the complication rate is so low, and then they give us the accreditation. So complications are part of what we do, but our job is to inform our patients, but more importantly, to protect the patient by putting in place measures that reduce the complication rate to very, very low levels.
Absolutely. So these are kind of the short-term risk of the surgery. So if we were to go into long-term risk and complications, so if you can also summarize those, and then I may have some questions.
Absolutely, absolutely. So there are really two important ones to keep in mind, right? One is potential malnutrition, right? So lack of nutrients. This is much more common with gastric bypass and relatively less with the sleeve gastrectomy. And the reason is simple. When we do gastric bypass, we are rerouting the intestine to make it unable to absorb nutrients well. Well, because we want the patient to absorb less calories, but and side effect of that is that their ability to absorb very important, what we call micronutrients, like minerals, like vitamins, also decreases. So to make up for that, we want our patients to be on vitamins and micronutrients for the rest of their life. Not only that, we want them to commit to follow up with us in the long term as well, so we can do blood tests repeatedly, right? If those things are not in place, then the patient is in danger of becoming vitamin deficient or mineral deficient. And if these things are not taken care of, they can be very serious. The person could be at risk for hair loss. They could be at risk for weakening of their bones. They could be at risk for poor healing or being vulnerable to infections. They could be at risk for irreversible nerve damage. So these are serious issues. So once a patient commits to something like gastric bypass, they also have to commit to taking these additional supplements for the rest of their life. Not only that, they have to have a medical person supervise them so that they can do tests on an ongoing basis to make sure that these vitamins are in place. This happens a little bit less frequently with the sleeve gastrectomy because we don't reroute the intestine, but even the sleeve gastrectomy requires careful attention to vitamins and micronutrients in the long term as well.
We do actually cover the multivitamin issue in a specific session.
Yeah, absolutely.
And we also tell people that not only those who are going through the surgery, but everyone should be looking into their daily vitamin intake anyway.
Absolutely.
But for our patients, that's a bigger risk that may be out there. And
yeah. So this is a long-term problem. Once we've changed the anatomy, once we have gastric bypass, this risk is going to be with the patient in the long term. Another potential complication that's actually on the flip side seen more with the sleeve gastrectomy than the gastric bypass is acid reflux. This is something we talk about. Now, this is not universal. It's very important people understand that not everyone who has the sleeve gastrectomy will end up with heartburn. In fact, to the contrary, some people who have a history of heartburn and they have the sleeve gastrectomy may become free of heartburn afterwards. So it's not a universal problem, but certainly we know that there are some patients on whom heartburn can become an issue in the long term. Now, this has different levels and different degrees. In some patients, it may be occasional heartburn that occurs with certain foods, and addressing the problem may just be avoiding those foods, right? In some patients, it may become a problem if they eat very late at night or close to their bedtime. So addressing this issue may just be eating much earlier, before they go to bed. In some other patients, they may require anti-acid medication on as needed basis, right? Other patients may require anti-acid medication on a regular basis. And it's a very small minority of patients. Even the anti-acid medications may not be sufficient, and we may be looking at additional surgery in the form of switching the sleeve into gastric bypass if this becomes an intractable problem in the long term. This is, again, a minority of patients. Now, heartburn, acid reflux is not something that is seen with the gastric bypass typically, but we see it more often with the gastric sleeve. So these are kind of a fairly common type of long-term problems. Another thing that could be seen in the long term, particularly with the gastric bypass, is the risk of bowel blockage, Kemal. As we have said in the past, one of the steps of the procedure of gastric bypass is rerouting the intestine. We are removing the intestine from its natural place and placing it in a new unnatural position, and that can lead the intestine to twist and cause a bowel blockage. And sometimes with a loss of weight and loss of fat, some pockets can form within the abdomen where the intestine can become caught. This is actually known as internal hernia. And about 10 to 12% of patients who had gastric bypass may require surgery to fix this, and they may even present to the emergency room with abdominal pain. So bowel blockage is a potential complication. It is less common with the sleeve gastrectomy. Sometimes some patients with the sleeve gastrectomy can experience stomach blockage if their sleeve becomes so narrow that they cannot get things through it, but that's really uncommon.
Hiatal hernia we are talking about?
It is actually different. I'm glad you brought up the issue of the hiatal hernia. Hiatal hernia is not necessarily a consequence of weight loss surgery, but it is a problem that can be seen in conjunction with weight loss surgery, because being obese, being overweight, puts patients at risk for developing hiatal hernia. Now, hiatal hernia is a type of hernia that occurs at the place where the food pipe enters the abdomen. The food pipe crosses our chest to get into the abdomen. Our chest and our abdomen are divided by a muscle known as diaphragm. The diaphragm has openings through which the food pipe will go through to be jointed to the stomach. Sometimes, if that opening becomes lax, the stomach can slide into the chest. That is really the definition of a hiatal hernia. And often it can be associated with symptoms like heartburn. And we discover that very often in our bariatric patients because we do endoscopy before surgery. And if the hiatal hernia is significant, we actually like to fix it at the time of the bariatric surgery. Sometimes additional surgery may not be necessary because the hiatal hernia is small or insignificant. Sometimes it may be significant enough for us to want to fix it. So there are different types of hernias. Hiatal hernia is one type. Internal hernia is another type. And there is another type of what we call abdominal hernia that can occur with any surgery, but can occur with bariatric surgery as well. Although it's not as common as when we used to do bariatric surgery through a big open surgery. As you know, when we did open surgery, we needed a big incision to insert our hands inside, right? Now we do the surgery by going through small, almost keyhole incisions. The chances of getting a hernia through those incisions is very low, but it can still occur. So hernias are potentially one of the long-term complications that can be seen as well. Another potential long-term complication, Kamal, is anemia, and this could also go with the malnutrition that I mentioned earlier on. And this is much more common in women than in men, but particularly after gastric bypass, the ability to absorb iron from our diet is actually lower. So we see women, for instance, who are still having their periods and losing, iron on a monthly basis. They can actually become unable to supplement their iron just by mouth, and some of them may require iron transfusion as well. So another important reason for committing for a long-term follow-up, because we can look for their hemoglobin level, and if it's low, we can address it in this way, essentially.
So, well, when we look at it from the pre-surgical standpoint, so there is we have a system in place. It's a multidisciplinary program that addresses the risk from several different aspects. So it's not just the surgeon, it's not just the nutritionist, it's not just the anesthesiologist, but the cardiology, pulmonary, primary care doctor. They're all they're all part of this process. So from the post-operative care, what we need our patients to do is to communicate with us in a timely manner. So don't wait on any of the problems, any of the issues that you are actually seeing, then just reach out to us as soon as you notice any changes. And also understanding that this is a change in our lifestyle in a way that we need to make this commitment and make these changes. Like this week, I didn't have a bariatric surgery, but I log every day what I eat, how I eat, what fasting that I do. It goes through a database. Everything is recorded, like how many steps I'm putting in. This is a commitment. So this is the change that we have to make ahead of the game. So then before we start, and then we have to follow. And in some cases, not understanding nutrition counseling, how important that is, because in many, we see many patients can benefit from ongoing support from a nutritionist, and they're available. It's a telemedicine these days. So it's convenient, but also it's extremely helpful to avoid some of these risks. So Dr. Irgau, in terms of collaborating with the other healthcare professionals and understand the risk, how do we actually work with those other specialties? If you can kind of summarize that for us.
Actually, we work very, very well. I mean, again, the issue is always about our initial assessment, right? When we are assessing the patients, we're looking for potential risk factors, right, for possible complications. So let's take, for instance, two specialists that we work with, right? Endocrinology and hematology, for instance, right? So if a patient comes to us and their diabetes is not well controlled, or they have a thyroid problem that's not controlled, right? We look at it. And then we have criteria. We say, okay, if the blood sugar is at this level, it's manageable. We're okay. Continue seeing your primary care doctor, and we will be fine for the surgery. Continue the medication that you're taking. But what if the patient comes now with a level that is so high that their risk for problems and complications now is magnified, right? Well, we want to control that. And we have the specialist, Dr. Handel's office, which is part of the United Medical Network, graciously takes care of our patients in a timely fashion, right? Sometimes they see patients even on Saturdays so that they understand what our patients are going through, right? So very often patients are trying to make an appointment with some other endocrinologist in town, and it may take them 3-4 months to find, an appointment, and yet the endocrinologist understands that there is a timeline through which our patients are working that need to be addressed in a timely fashion. So they see our patients, they put them on the right medication, they do appropriate tests, and then they release them to our care for us to be able to undertake the surgery with less risk. Same thing with hematology, for instance. If a patient has a history of blood clot, for instance, we send them to hematology to see if they have a genetic predisposition, and there is a whole workup that the hematologist does. Or if the patient is found to be having abnormal blood counts for reasons that are not very clear, then we send them to hematology, and all these are addressed. And the same thing with cardiology, the same thing with pulmonary, and so forth. So it is a very well orchestrated setup, right? Well, everything is really put in place to maximize safety. It almost reminds me what the airline industry has achieved and has done, Kamal, right? If you think about it, people nowadays forget the fact that it is safer to fly than it is to drive a car in the highway, right? And with millions of people flying every day, the chances of accidents is extremely small. And the reason is because the airline industry has put in place checks and balances, really, that look at every potential possibility and they address it in a proactive manner. The same with bariatric surgery. Also, we have all these things in place that have really resulted in the safety levels that are extraordinary when you look at them, when you look at the magnitude of the surgery, but also of the patients we're taking care of. These are very unhealthy patients, Kamal, that have diabetes, that have high body mass index. They may have sleep apnea, high blood pressure, heart disease, right? And yet we're able to get them through this surgery with such level of safety. And that is because we are educating our patients. We're getting them through checks and balances that are really focused on minimizing complications. And it's no wonder that complication rate is so low.
I want to point out one thing, and we try to make these points time to time, but so in life, everything can happen. So in terms of our health, there's a lot of ups and downs. The thing is, when those times happens, when we have those downs with health, we want to be at a minimum risk from our, where we are, our like current situation. We don't want to actually add to that risk. For example, like Kate Middleton, the Princess Kate, I guess. Don't ask me why I'm following this, because media is just pushing it to our face, so I have to know. But apparently she had cancer. 42 years old,
Ooh,
right?
okay, I didn't know that.
She was hiding for about a couple months now. Today she came out and then she said she had cancer. So 42-year-old, physically she's in good shape. The problem is if she wasn't in good shape, if she had morbid obesity, so this cancer is going to happen, but it's going to be more severe if she had morbid obesity. So if she had gallbladder surgery, she's going to have a higher risk with the morbid obesity. If she has heart disease, she's going to have a higher risk. So the actual risk is the morbid obesity itself. So then every other risk, we need to kind of weigh them. And then as we do this in our program to minimize pre and post-surgical risk, and as you kind of point out time to time, we have this necessary redundancy in place so that it's not once, it's not twice, it's 3, 4, 5 times in many cases that we check and then make sure that everything is captured properly. And because we don't want to take that risk at the OR table, on the OR table. So we want to make sure that there's a pleasant experience before and after, but we want to at least at a minimum, we want to be able to go home and sleep, knowing that we did everything that we could, and that's how the program is operating. But main focus and main point for all of us is that those things are going to come to us, so we need to prep, and then that prep needs to happen ahead of time. So it cannot happen after those things are happening. So dealing with all those health issues is better when we don't have morbid obesity. So that's kind of like the bottom line. So, Dr. Ergau, I think we explained all the different aspects of risk and complication. Now we do have a playlist of specific topics now. Because we have done these sessions 6-7 times in the last 3 years. So they're in a specific playlist on our YouTube channel. They can actually, if we didn't capture something, we talk about something else in a different episode. They can always catch those issues in the other videos. But thank you for joining us.
Of course. It's always great to be here, Kemal.
We'll be back next week with another topic, and we're hoping that everyone can follow what we are actually trying to do here, and we can be helpful for those who are looking for help. Again, thank you and have a great weekend.
Bye-bye, everyone. Thanks.